minutes into the session. Dr. Springer, also good afternoon. Staff of PANCAP and other staff of the CARICOM Secretariat. Good afternoon and welcome to the session. It's justice for all, and in this case, fast-tracking the end of AIDS in the Caribbean. And who else? I mean, I don't think anyone else could have done it better or will do it better than Dr. Greene. And I think I can still say our own Dr. Greene, right? Because if I compare the amount of years that you're outside of the Secretariat, compare the years that you spent in the Secretariat, right? The time out is still far less than the time in the Secretariat, right? So you're still one of our own, if I may say so. And with all your experience, I don't have to go through your CV. Everybody knows you in the region, in the Secretariat. I would like to thank you for visiting us and for giving a presentation. When I was approached by Mr. Springer, DSG, Kuchu, I said, that's no problem, let's do it. This is the first one, and we'll have another brown bag lunch. I think it's on the 17th, Mr. Springer? 1/7 of July. Yes, next Monday. And since Dr. Greene is here, there is a proposal that we do a workshop or interactive discussion session, whatever you want to call it, with the children of the staff of working within the CARICOM Secretariat. Because it's summer vacation, right? And maybe we're thinking children from 10 up to, I don't know what age, who are in their summer vacation period. We will invite them to the Secretariat, and we're going to have a session with an appropriate title for them. It's going to be interactive, okay? And the thinking is that we should have that session immediately after lunch. Why? The parents during lunch can go home or wherever, collect the child and bring him or her or them to the Secretariat. We will try to have like a 2 hour with a half-hour break. And that's why I'm saying interactive. It should not get boring for the children. And then when you leave on time from the Secretariat at 4:30, then you can take the children with you. So that's yes, they will have a snack. I don't know if you will have a snack, but for sure the children will have something. That we will have a half-hour break. That's the thinking. But I'm putting it here on the table so that you are prepared of what is coming your way. And then we don't want something like this, but we want an interactive group, and we're thinking to having them upstairs, not here, right? So having said that, and what we have ahead, Dr. Greene, you have the floor.
Thank you so much, DSG, and welcome. And it's a pleasure to see old friends and some new ones. I met a new friend from Trinidad and Tobago. But I want to show you that, like Elizabeth Taylor, who told her, 7,000, I shan't keep you very long. I will tailor this presentation not to be interactive, but to really help us to think about the issues, and I will tailor it for about 12 minutes so that we can have some discussions on the way forward. But I want first of all to say, DSG, I have seen you in operation at more than one occasion, and in particular at the Parliamentarians Forum. I know your passion. I know that you could get people to do things that they don't otherwise want to do. And that's what I call powerful leadership. So thank you for your leadership. Now, I wouldn't go into too many of the details, but Justice for All speaks for itself. It means leaving no one behind. as we move towards ending AIDS. But I think there is a context that for Secretariat staff, we need to really know how we move our programs, and especially programs, the social sector, climate change, poverty programs. We're doing those in the context of the current 2030 Sustainable Development Goals. There are 17 of them. And the one that really relates to the discussions that we would have this afternoon is Goal 3, dealing with good health and well-being. But there are so many others, but I brought this to your attention because in programming your work in the Secretariat, it's important to make reference to these goals. In the context of the topic this afternoon, when Derek first became director in 2013, September, he had a discussion with me and he indicated, look, I would like to take the program for PANCAP in a direction that is dynamic. And he thought that he wanted to zero in on the 2011 political declaration of UNAIDS, not UNAIDS, of the UN system, which really had to do with eliminating stigma and discrimination. And as you know, in the Caribbean, this is one of the major and intractable problems. And so the Justice for All program was initiated, and the title itself had to do with how we deal with elimination of discrimination. But the concept was broader than just dealing with discrimination. The concept had to do with how we deal with family life and focusing on those in need. This was particularly relevant to the faith leaders who wanted us to insert into our program the concept of family and family life. But then there was the other issue which we had to deal with, treatment, how we access treatment and affordable medicines. And along the way, I don't know, you would have heard of the 90-90-90 targets, meaning if you get 90% of the people living with AIDS tested, if you get 90% of those tested on treatment, and if of those on treatment you got 90% with viral loads low enough as not to transmit the disease, then you could eliminate AIDS. Now, that is a scientific projection, and the Justice for All program adopted it. It is called treatment as prevention. But it also had two very important concepts around it, both dealing with prevention, reducing gender equality and violence against women and girls, prevention, promoting sexual and reproductive health and rights, which is age-appropriate education, how you prevent people by giving them the knowledge. And then there was the overarching one of implementing legislative reforms for modifying AIDS-related stigma and discrimination. And we'll come to that in a short while. So that this Justice for All is really a concept of how we move people, institutions, organizations, along the path towards eliminating AIDS by 2030. I just wanted to bring to your attention what are the elements. There are 15 elements of the Justice for All. And since I'm told by PANCAP that you would have, this would be distributed to every one of you on the website, I wouldn't go through in detail. But in fact, of the 15, 8 of the 15 elements of the Justice for All roadmap are quite achievable almost immediately. And I just point out one, making the Caribbean the first region in the world to eliminate mother-to-child transmission. That is an aim that could be done by 2020 in this region. Developing special programs for and special facilities for the disabled, and strengthening the laws related to domestic violence, and a series of others, advocating for development partners to review the practice that really penalizes the Caribbean by being middle and upper income countries, and therefore excluding them from concessionary funding, with very serious implications for development. And these are some things that we have we have to advocate about, and it's all in the declaration and in the roadmap. There are some longer term issues. There are medium term, which I skipped, but longer term ones, which means that we need to engage in the systems and the discussions about accelerating the repeal or modification of laws against sexual acts between consented males and female adults. And we're thinking about replacing them with provisions that really have very important implications for how we deal with our programs in the future. So in a nutshell, the PANCAP Justice for All roadmap covers a broad range of actions, some of which I will come back to in the discussion. I'm not going to go through these next slides, but when you get them, you will see what I was trying to do. I was suggesting that 2016 was a watershed in the UN system, and there was a political declaration in 2016. The PANCAP Justice for All program was conceived in 2013 and modified in 2015. And what you will see is that, I'm trying to show, is that the political declaration, the elements of the political declaration of 2016 really parallel the roadmap for PANCAP. And these next slides show that. I just give you an illustration. Doubling the number of people on treatment and the implementation of 90-90-90. And for PANCAP, it had to do with universal coverage by 2016 and supporting the initiatives aimed at increasing access to treatment. So if we went along the two columns, you will see how the political declaration of the UN parallels the PANCAP Justice for All program. But here is a parallel, financing the end of AIDS. One has to increase investments. And investments now, because we are being marginalized by the funding agencies, by being middle income and upper income, means that we have to find the resources from within the countries, and this is an important thing. And you will see in PANCAP is to increase access to treatment, including affordable medicine. Now, but what is important for us to note when we are dealing with these roadmaps is that we're talking of a situation where people living with AIDS are now dying of other diseases, TB, NCDs, hepatitis C, and so on. And therefore, when we are moving forward, what we are doing is trying to take AIDS out of isolation. And I'm pleased to see that at the heads of governments, there was a recognition of the 10th anniversary of the Port of Spain Declaration on NCDs. But what needs to be noted is that AIDS and NCDs are parallel, because to the extent that the immune system, because of the affliction with HIV, could be diminished, it then increases the possibility of other diseases entering the system. And therefore, I think that when we as CARICOM move forward in this period, we have to see an alliance and seek an alliance between HIV and the integrated health process. So when you're talking about testing, you're testing for a series of things, HIV as well as NCDs and so on, in one holistic system. Now, it's something that we need to think about as CARICOM and as the CARICOM Secretariat. But I wanted to go back a little to the science. The science is very clear. The science is very clear that if you could get 90 people on treatment, 90 people knowing their status, 90 on treatment, and 90 with viral loads, we can end the AIDS epidemic by 2030. Now, this is important because we do not yet have a vaccine for HIV. If we had a vaccine, we could eliminate it by 2020, but we don't have a vaccine. So HIV is a life cycle approach. You have it, you have to treat it, and you have to try and get your viral load down. And that is an important factor. For children, I'm glad that we're going to have the children. The children will have to start free. That is from birth, start free and stay free. And they have to do all those things that would get you to 1990. But what is important about that slide, it shows that at the present trends, the Caribbean is far below the first 90. And that at this rate, we will only be able to achieve about 40%. I can't see that last figure. 30%. We will only be able to achieve 30% of the people living with AIDS with viral loads low enough by 2030 if we continue. So it is very important for us to note there is a lot of work to be done. Getting tested, getting treated, and keeping viral loads. So that is the important task for PANCAP and the agencies and for all of us who advocate. So AIDS is not report of July 2016, that's the latest report we have, indicated that there has been a spike in new infections in the Caribbean. That is disturbing because after 5 years of decline, in 2016, looking at the 2014 to 2016 figures, it shows that in the Caribbean we had a 9% increase, mainly in Cuba, which I don't think is on that map.
Yes,
it's there. Mainly in Cuba, Jamaica, and Haiti, and to a less extent Dominican Republic. And so what we have to find out is why the spike, and the guesses are that people have become complacent. We think the thing is over, people are not dying as much, so governments are complacent, individuals are complacent, institutions are complacent. To give you an example, Guyana and Trinidad and Tobago, last year and the year before, there were stockouts, meaning not sufficient drugs for people living with AIDS. Stockouts, so it meant that they did not have sufficient drugs, as a result of which you can tell that you have a little spike. And the other thing about it is that we are finding in some of the reports recently that the spike is among certain populations, including young girls. Now, there is no major evidence as to why, but there are speculations. What is interesting is that when we are dealing as the CARICOM Secretariat, and I see we have Dr. Cummins here, and as the Health Division, we have to tackle the approach which is very integrated. Now we have HIV, TB, hepatitis, NCDs, and the report last weekend from WHO is now telling us that gonorrhea is on the rise, and it's a virulent strain, and the drugs are not available to treat it. Now, if on top of HIV you have gonorrhea the next year, you can imagine what could happen to small societies like ours without the necessary capability to deal with these things. So what I'm proposing to you is that an integrated approach is required. That slide is self-evident when you read it, and therefore testing is important and treating immediately. That is the other problem we have in the Caribbean. People are tested positive, and the science is telling us that testing positively and going immediately on treatment is one of the guarantees for reducing viral load. In the Caribbean, we have examples, whether it's Trinidad, Guyana, Jamaica, that the delay in treatment is as widespread to be worried. And therefore that could be a cause of the resurgence. Now there are other things there, including what we normally call the social barriers. And they include people who are in the marginalized communities, the poor, the people who don't have access to information. All those things are additional factors which compound the problems that we face. And therefore, I think when you get the slides, if you look at this carefully, you will see the suggestions, the policy suggestions for corrective actions. What we find in the Caribbean, too, which is very worrying, is that when you look at the data from the UN, WHO, PAHO, for the Caribbean, there is always such a large amount of missing data. We have a weak data gathering situation, and this is another area in which CARICOM could play a critical role. I know that the statistical division has been making a pitch year in, year after, but the situation in the Caribbean with respect to data gathering is extremely serious. Substandard government clinical facilities. A report just came out showing even in Trinidad there has been a slippage in the facilities. I mentioned medical stockouts. I need to mention that PEPFAR, one of the countries, the American program that is so popular, is really transitioning countries, except Haiti and Jamaica in this region, from funding of the AIDS agenda. So all these things are happening, including the legal barriers that we will speak about. And therefore, really, what I want to suggest to you, the very important component that we have control of is combination prevention, preventing the youth, preventing the aged, preventing all of us from getting the disease. And this really gives you an idea of what are those combination things. Whatever you think about your being faithful and things like that, there is no other preventive thing than using a condom. Condoms, the use of condoms, the access to education, and the sexual, the knowledge about how you get the disease. All those are important parts of the combination prevention. But I want to just end on the PANCAP engagement model, which I think is a model that has helped immensely, and for which I think PANCAP could again escalate its operational programs to be a best practice. In about 2015, the director and myself and some senior officials had a discussion about how we can change the trajectory of our advocacy. And what happened was that we thought that it was important to have discussions discreetly among special stakeholder groups. And we had discussions, and we started those discussions. I just briefly highlight some of the results of those discussions. Faith leaders have agreed that they will have an engagement later this year, hopefully on World AIDS Day in December, with representatives of LGBTI on how we move forward to end AIDS by 2030. Now, I hope you heard me. Faith leaders agreed to have a discussion with representatives of LGBTI. If you know where we've come from, this is almost a revolution. But it is a proposal, and PANCAP is working to make that happen. The First Ladies have introduced the network to champion causes dealing with women and children. The youth have come up with proposal on peer counseling, and I won't go into detail here because we're running out of time. And the private sector, which we are now engaging about their social corporate responsibility of helping to take the financial gap which is being created by the pulling out of many of the external agencies. And civil society, important, especially people living in AIDS, being engaged in the process. and the media strategic information on how we can fast track. Now, lastly, we had a meeting in which DSG attended in May, the end of May, and parliamentarians agreed that they would implement and it was DSG's instigation and insistence, and they agreed that they will implement the PANCAP anti-stigma and discrimination legislation, and which focuses on the repeal of bad laws, which will help to eliminate stigma and discrimination. Now, these are just snapshots of what has happened, and I want to just show you the faith-based organizations, the parliamentarians, and so on. And this is really a snapshot of presentation to the Clinton Global Initiative last year by Prime Minister Timothy Harris, the Minister of Foreign Affairs of Jamaica, Kamala Johnson-Smith, First Lady of Guyana, and the Secretary General of the Commonwealth Secretariat. And so, really, what I want to end with, oh shucks, well, it's ending for me. What I wanted to end with is to say, what are those opportunities that we have using our stakeholders to facilitate the end of AIDS? First, what is happening based on the PANCAP model that we are using of consultation is that we have established regional consultation for the stakeholders, faith leaders, parliamentarians, youth, and so on. Secondly, we've convened national networks with broad-based representations. So that tomorrow we are meeting with the Guyana Network of Faith Leaders. We previously met with faith leaders throughout the Caribbean over the last 2 months. And I mean, if I were to tell you the stories that have come out, you would be surprised at what is the progression of events among the faith leaders. Then there is the PANCAP Communications, the website, which was launched on Friday as a hub. Most people will now be able to relate to that as a non-learning. And then we have developed, and PANCAP is developing in collaboration with its partners, an M&E capability, a little more robust for collecting and analyzing information for policy making. And then hopefully you will hear about the revival of the Champions for Change, in which we hope that we will have champions from each of the faith leaders, from each of the stakeholders, coming into a collective leadership to help us to get to the point where we in the Caribbean could be the first to have eliminated AIDS. Now, for me, if we can do this, DSG director, colleagues here, if we can do those things in advocacy and achieve them, we could sustain as an international best practice. And we need to be proud, and we need to make every effort to sustain PANCAP as an international best practice. Thank you very much.
Thank you very much. Thank you, Dr. Greene. Yes, a lot went into what has been achieved by our PCU and by PANCAP today. I don't want to go through the whole history, but you need some stalwarts, some people who really, take the thing forward. And one of them is, of course, Dr. Greene, and then we had the PCU before, and now current director. Talking about stalwarts, Ms. Bernard just joined. I welcome her. But before I continue, I must express my sincere condolences to especially the staff who know Ms. Faye Yusti very well, as a friend, as a sister, as an advisor, because earlier today we heard that she passed away. She was sick for a short period of time. And last week, I also got to hear that my fellow country lady, that's Miss Ariela Del Prado, who also worked here for a few years in the legislation directorate, she passed away last week also. And I don't know what to say, what to link, but anyway, it seems like the root of sickness or something, I don't know what to say, something seems to be going on, and it was mentioned here, but I don't know what to think of it. So my sincere condolences to all those who, were very close to Mrs. Faye Houston, also one of the stalwarts of the CARICOM Secretariat, starting in the Guyana Central Bank, coming here, and then due to circumstances, she had to move, but she remained within the community, then working for CDF, and she was there from the very start of CDF. That is important to mention when we were dealing with how do you get the resources and so on and so forth. So yes, we will feel it, the gap that we'll have now to deal with. So I want to thank Dr. Greene, and the floor is now open for questions. Yes, Dr. Cummings.
Thank you very much, DSG, and thank you very much, Dr. Greene, certainly Derek, and having him come here and his presentation. You did allude to the data gathering gaps which exist in the region, and I want to bring some words of hope. That 2 weeks ago in Barbados, there was the first face-to-face meeting of a technical working group supported by the Pan American Health Organization, addressing the issue of information systems. Just about the same time, there was a meeting of AIDS program managers and other senior functionaries in ministries of health for the same express purpose of looking at the situation with data gathering for HIV and AIDS. And I think on the second afternoon, we had a conjoint meeting, in fact looking at areas where there can be some achievement of synergies based on the general trajectory of where both initiatives seem to want to be going. I am hopeful that coming out of the 30th COSAD, which mandated that we have a ministerial meeting on information systems, in which the meeting took place in Jamaica at the beginning of the month of November. It was coterminous with the US elections, I recall, and which has in fact developed a roadmap for data gathering and dissemination, that we'll be able to be optimistic that that situation, for which the Caribbean should not be in that kind of situation, an analysis.
All right, thank you. You made mention early on in the presentation about the decriminalization of intragender sexual acts to help combat the spread of HIV. I was just wondering how the link between decriminalization and the reduction in the spread of HIV, please.
I'll take several.
Okay. We will take several questions. Another question? No one? Yes, you okay? Go ahead, go ahead.
With respect to the the HIV vaccine, that's probably. It's my understanding that in the beginning, when they started trials with vaccines, it meant that the person getting the vaccine will always test positive for HIV. Has that changed in recent times?
next? Yes, please. Yes, Miss.
Yes, I noticed, well, because I came in a bit late, but I did get quite a bit of the presentation, and I want to commend the presenter. It's quite fascinating information and very relevant to all of us. I just want to share a bit of some experience I've had. And when I heard Dia's question about the decriminalization of intergender activities, and also the comment you made about the faith-based leaders interacting with the LGBTI group, it made me think of an experience I had. In Trinidad and Tobago, I used to visit the home for children with HIV. And I remember many persons didn't understand why I would want to interact with these children, because they were fearful of the disease and of their ignorance as well. And I remember married to is an exposure to that. It's because our education about the disease and about these illnesses needs to be as basic as that. When I was growing up in school, they would come in and tell you about reproductive health, and this is primarily from the Johnson & Johnson group in order to sell their products. What I'm saying is that you need to go into the schools. You need to tell the children about sexual health and sexual diseases, and you need people to understand it's a heterosexual disease as well, so that there is no level of comfort that I think people seem to take on, that it's not going to happen to me. It's more likely to happen to you through a normal process of falling in love, dating, getting married, than interacting with children who are HIV positive. Thank you.
Thank you. Yes, please. Yes, Miss. Thank you, Miss Bishop.
First, I want to thank Dr. Greene for a very good presentation. What I would like to say is about the advocacy and the use of products that we have made here in the Secretariat as well. And I remember that the Secretariat produced a film, Smuggleful, which means gossip, a while ago. Unfortunately, we do not have that much information on how well these products are being used, and if they are still being used, which in terms of the advocacy on preventing stigma and discrimination could maybe also address that we evaluate the use, that we see how much of the information is still valid, and maybe to, if it's still a product that can be used, just, you know, refurb it, make it more available. We have YouTube to address that issue. Thank you.
So you're talking about awareness. Yes, thank you. Ms. Bishop.
Thanks, ESG, and thanks, Dr. Greene, for the very informative presentation. This is just a follow-on from my colleague. I also would like to suggest that we need to do more work with our cultural practitioners. You have indicated that the young women have been, the increase has been within young women, and we have to look at our carnival celebrations and have our cultural practitioners involved in this fight. Thank you.
Thank you. Who else? Yes.
Thank you. This is a suggestion or a statement more than a question. Because I was wondering, as you made your point and you said that there was a sharp increase in girls, I was wondering whether the role of social media and access to pornography may contribute to that. Thanks.
Thank you. Anyone else? Yes, please. You have a question? Yes?
I wanted to know about the practice of circumcision. I don't think it's a cultural practice in the Caribbean, but I know you said that it's a preventative measure. encourage people to accept that daily practice in the whole program of preventative measures.
Thank you very much. Who else, please? Nobody else? Okay, and if I may, Dr. Greene, the link between HIV/AIDS, being HIV positive, and STDs. I saw, for example, gonorrhea, and I was listening to a BBC documentary whereby they're saying now that certain, how do you call these things? Yes, and so on, the human body is not reacting to it anymore. So they have to now come up with other vaccinations and so on and so forth, because it seems like we're building some resistance. So how do you see that linkage, and where are we heading with that in our programs and creating awareness? And the other one is, it was mentioned awareness, but I very recently, and recently meaning even yesterday, was confronted with a situation whereby, how can I say this, in a certain sector, people, let me tell you how people speak about it. Oh, you know, mistress, you know this and this person? I said, yes, working. So I said, okay. You know, he died. I said, okay, of what? Well, these women talk about it so and so, but you know, nobody knows, only God knows. And 2 months before, from in the same sector, someone else had died with whom I had spoken, and I had said, listen, with your brother and women, please be careful, and so on. And not long after that, the same person to whom I was talking, he passed away, right? HIV/AIDS. So I don't know if it's ignorance or what it is, but I don't know what to say. So how do you deal, do you tackle these types of ignorance or not realizing, leaving everything to God, you know, and we will see. But in the meantime, what is happening? It's spreading. It's spreading, right? And people live in denial. They don't want to accept it, and it is God. Unless God tells us, I don't believe it. But then by that time, you're not there anymore to tell it, right? So how do we deal with these situations? Thank you.
Now I'm going to enlist a couple experts to deal with about 2 or 3 of the questions and the issues, but I thought the interventions were all very, very important. Glad to hear about the data, the initiatives and data from Rudy. Want to deal with the question of criminalization and the risks. What the evidence is showing is that decriminalization of the laws by themselves will not necessarily make a big difference. But what is important to note, because the laws are in the books, that there are certain influences like the police and the health workers that contribute towards stigma and discrimination, and that really contribute towards people not wanting to come forward, especially people engaged in same-sex sex. And as a result of which, remember that first 90 getting tested? That is one of the big problems. We're not getting to the groups that need to come forward for testing. And therefore, this creates a revolving cycle. So that I think one of the issues that we must place emphasis is adopting the strategy of getting to those marginalized people despite the laws. I'm saying that there is a connection, but despite the laws, because even if you got the laws off the books, if people still discriminate in the health sector and the police and so on against cross-dressers, you still would be in the same problem. And so I think that one example that I would give is the Jamaica AIDS for Life program. That's the name. AIDS Support for Life. They treat people, they get people tested and they treat them. But they don't only deal with the AIDS problem or the HIV problem. They also outreach to nutrition. They also outreach to helping mothers, young mothers in particular, to have daycare services. And they also deal with issues related to poverty. In other words, they see it as a community-based responsibility. But for the Jamaica AIDS Support for Life program, the Jamaican figures would be worse. Only 37% of the people living with AIDS are on treatment in Jamaica. If it weren't for the life support, it would be less. The projection is it would be 14. So it means that in dealing with AIDS, you have not only to deal with the issue of AIDS, but you have to deal with this, what they call the structural factors, the poverty, the nutrition, and so on, how you get people involved. So I'm saying that the problem really, although we want to decriminalize because we think the laws are bad, by itself it may not work unless you put other factors into play. And here is where we found the religious leaders coming into play, because their role is to reach out to those people in need, okay, and to help to build a constituency. The second issue about trials, I'll ask Derek to speak about. But I want, having said about Derek, the question on awareness is, I think those questions are important. You talk about the products. I think that when we met with the youth in Trinidad, they explained to us how you need to move the products and revamp the way that you deal with products. So I remember the discussion in the working groups where they said, this red ribbon that we wear, that doesn't attract a youth to support this program. What it does, it's really a very negative way of projecting AIDS. What we need is the more positive approach. Like, for example, I don't know if you remember last year, we had something called Hands Up for Prevention, which means that you're being more positive about how you're dealing with it. And so that youth symposium was an eye-opener to me, because they said that we need to revamp the products, so that the people that we are projecting them to, in particular the young people, who are infallible, you know, they think so with respect to STDs and all that, you know, use of condoms, you know. And so I think that we need to go back to the table and see what are the relevance, what are those products that are relevant to how we project to various target groups. And then I think that everybody spoke about practitioners. It's important for us to deal with those carefully. And I think that I once thought that one of a good mass band in Trinidad and Tobago would be and people, and then had a calypso about it, and then had a play of it, which would reach people and touch them where it most is. The role of social media is what the youth said also was important, the role of social media. But they didn't only think of social media in the sense of YouTube and so on. They thought of it in terms of, and I think Rihanna will be pleased with this, escalating animation, which will reach young children and also reach older children. Animation, get them involved. So for example, if you ever looked at the TV and you see the projection called virtual reality, where people actually feel that they are in the situation. They actually could feel that if they did this, they will contract AIDS. Or if they contract AIDS, they could actually feel what it is they must do. Virtual reality is also a new mode. In other words, when you talk about products, I was saying what we need to do is talk about how we revamp the products so that they could make a difference. And they're experts. And one of the things that I believe CARICOM can do is to have a discussion among the media and experts to see how they can. And it not only with AIDS, we can deal with integrated health, NCDs, TB, hepatitis. We can deal with a whole range of things with the same kind of, I would say, modality. And let me then talk about prevention, including circumcision. This is a program that was being piloted in Africa by PEPFAR because it was found that that uncircumcised males were than circumcised males. The expert will be able to say a reason why. But the point is that then the program of circumcision, voluntary circumcision, was introduced in several countries, and the results seem to support the view that circumcision is an important preventive measure. Now, I will tell you an anecdote. A couple African chiefs met, and they were talking about the circumcision, and they said, you know, this is a ploy by the white man to help us to be impotent. Now, that is what you call being skeptical. But the point is, the science is saying that circumcision is an important preventive measure. They're also saying that something called PrEP, pre-exposure prophylactics, that taking it like you take the pill to prevent pregnancy is an important aspect. But here again, we had to overcome challenges by the religious group. What you were doing is encouraging promiscuity. But the point is, that is a preventive method which seemed to have worked. It is expensive. And our first ladies, I must tell you, are now negotiating with Gilead company, and they have promised to reduce for the Caribbean the pre-exposure prophylactics from $700 per tablet, which you use once a month, to 17 US cents for a tablet. And here again, I mentioned the power of negotiation as a CARICOM group, and that the First Ladies, I think that the discussion, you will hear more about that discussion. Finally, for me, I wanted to say that you're quite correct. Whatever we say about this disease, it remains a heterosexual disease. And I want to make it quite clear, according to the analysis that we receive, anal sex is not something which is located only between men who have sex with men. It is something which is practiced fairly widely, apparently, even among young girls. And apparently, young girls, especially those disposed towards maintaining virginity, and therefore, again, could be one of the reasons why we are seeing some of the spikes that I referred to among girls, because the practice of anal sex is apparently very prominent, and the study in Jamaica showed that this is what's happening, and that it is not only a gay thing, it is also practiced among heterosexuals. So the risk that you associate with anal sex is something which is more generalized than we believe, and therefore prevention is an important aspect across the various sexual-oriented groups. I think there was your question, DSG, which I want to ask if the expert on my right could answer. And the one on the trials, my expert on the left, if you can deal with it.
I think what has been of particular bother to the health community has been the fact that the research in the development of antibiotics, which in this instance are used to treat diseases like gonorrhea, has not been of the same level as it had been after World War II. And so there are less and less capable antibiotics of treating many, many infectious agents. What has been discovered is because of the, I guess, the casual use of many very powerful antibiotics for other things for which antibiotic treatment is not warranted. These diseases, organisms, not in a purposeful way, but in a casual way, and they develop, and the organisms develop resistance eventually. I should say that what has also been guilty, what has also been at fault as well, is the fact that there is widespread use of antibiotics in animal husbandry, in rearing of cows, chickens, sheep, whatever. There has been the practice of prophylactically giving these animals antibiotics when they're at a very young age, when they're vulnerable to all kinds of infections. We, in turn, when we eat the meat from these animals, we imbibe antibiotics on a very minuscule basis. And if perchance you want any infection and it's not being treated with the correct dose of the antibiotic, but these, what I would call lower doses, much, much lower doses, what it does is sensitize the organism to this threat. The organism then revises its genetic material, which allows it not to die when it comes into contact with a full dose of the antibiotic. There's another article, I think, which is, I think I saw late yesterday evening, which says that etiologically, which is in terms of the origin of this type of illness, that is the antibiotic resistant gonorrhea, has been the practice of oral sex, because these resistant organisms remain in the oral cavity, and you don't have the same expressions of signs and symptoms like you would have if it were closer to your sexual genital, usually inflammatory effect. And so there is this possibility of longer cycles of transmission from an infected person that would happen if the signs and symptoms were seen in the traditional sexual organs, which happens almost immediately if you have gonorrhea. Those of you who are from Guyana would know that there's something people call leak, which really is when you start dripping infectious material in the form of an inflammation. So it definitely is a threat, but it is part of the reason why the UK government, under I think it was Prime Minister, what's his name? The penalty Prime Minister has made a significant increase in its research budget to combat the holistic. Cameron. They've made a significant increase in their budget to counter the thing called antimicrobial resistance. And in fact, in the region, our institution, CARFL, has a grant from them so to allow each country, each member state in CARICOM, to develop a program to look more generally at the whole question of antibiotic resistance. It's a serious health security risk because in the traditional days of biological warfare, one of the things they did was to stimulate the production of microorganisms which would normally be susceptible to antibiotics to become unresponsive to antibiotic treatment. Thank you.
And thanks for the question about the vaccine. And there's been quite a lot of effort and money that would have been invested in trying to find a vaccine. We've had some false alarms, but to date we have not been able to find a vaccine. What we have been able to do is provide treatment. And I was wondering whether your question was related to what Dr. Greene said when he talked about the viral load becoming undetected, because one, in terms of better health outcomes, so they will have less opportunistic infections and have a longer life, but the person will continue to live with HIV for the rest of his or her life.
If I may, now that's an interesting, but pure answer is all vaccines create an immune reaction in your body. That reaction is coterminous with the existence of chemicals in your bloodstream, which says that you have come into contact with the infectious agent. Because what a vaccine actually is a less virulent form, a significantly less virulent form of the specific infectious agent, but which is 100% competent to produce the same kind of immune reaction, which will then protect you against the real organism if you were to come in contact with it. So all vaccines, persons who have had vaccines, if you do an immune test for them, you will find it to be positive for the specific agent against which they are vaccinated. You will, however, not find the circulating infection in their blood. So in future, if we do have a vaccine that's effective, the way how we will differentiate somebody who is positive by virtue, immune positive by virtue of their vaccination, is that you will apply one of the same tests that looks for live organisms in the person's blood, and you won't find anything. The same viral load tests and so on, you won't find those. Okay, so that's how they will, because I know that's a question you were asking. How do you differentiate? How don't I get stigmatized for having a positive, for being positive, as opposed to somebody who was infected? And the answer is that you won't have any live organisms if you had a vaccine circulating in your blood.
I think it's very interesting, isn't it? Any other question?
Two things occurred to me while you were responding, and one is, are you including in the decriminalization agenda prostitution and sex work? And two, is there any consideration for female condoms in the promotion of condom use? Because I think that's something that's becoming more and more common, because culturally, and that came up, there is some aversion to condom use in our communities. So would the female condom, promoting that, help increase the use of condoms?
There is the female condom, and initially you had the FC1, and then they improved it, the FC2. The challenge we have had is that in evaluating the use of the female condom, particularly to get feedback in terms of whether people were willing to accept that condom, is that a lot of women have reported it's noisy. So women have reported that. As someone who, as a consultant, did the evaluation, I'm speaking from that perspective some years ago, women see it as noisy. It's much larger, so it's not like the male condom, it's larger. And for many women, the concern was in terms of how their male partners will respond to that. For the women who indicated that they were more likely to use it were women who were sex workers. And those women felt that they had much more control because they can insert it before, so they don't have to wait until they're about to have sex. They could insert the female condom before. So we've had some challenges in terms of acceptability based upon some of those experiences. We have not had as many of the female condoms to be able to provide those condoms to every single woman that wanted the female condom. And I think that if we were able to do that, we might have been in a better position to determine whether more women were willing to accept it. I think the challenge, though, is that the work was only done with women as opposed to also doing that work with men. Because the women were more likely to use it also when the male partner was comfortable with her using that condom.
I just wanted to say on the issue of the laws, yes, in the parliamentary session we had a very good discussion on including sex work, legitimizing sex work as sex work. The jury is still out because there are sides of the issue, but parliamentarians are resolved to discuss it and see how we can move forward. We had a very good case made by a sex worker on behalf of the Caribbean sex worker group, and I think for the most part people understood that this was an important part of social development. Well, I wouldn't say social development, of social activity, and it has been with us from time immemorial. And some people are willing to deal with it in a more positive way than others. So all I'm saying is that the discussion, we are aware of that discussion, and I'm not so sure what will happen in the eventuality.
Thank you, Mr. Springer and Dr. Greene, Dr. Cummings. 1 more minute. Anyone else? No? Okay. Yes, please.
Just one last statement. I just wanted you to know that the Anglican Diocese of Guyana has recently launched a Human Rights and Social Justice Commission, which is a step forward in terms of trying to allow the faith leaders to become more, I'm not sure if liberal is the word to use, but liberal to the interaction of people with different sexual orientations and just human rights in general. All right, thanks.
Is it possible, because we're having the faith leaders consultation tomorrow, I didn't see that group on. Andrea, was the Anglicans, did they confirm? Because if you probably could share a contact, I know it's just 24 hours out, we may be able to send an invitation to them. Thank you.
Thank you. And maybe when you go back, you can start to make a few phone calls. The value and part of this session, then Mr. Springer, the value and part of this session, you see how the secretary then can also assist for you getting yes. Yeah. Anything else? Any other question, comment? No? Yes, please.
Just one final comment. In addition to all the work that's being done, by the institutions, by the schools, by the civil society, of course it starts with the parents, because the children are going to hear everything and learn everything that is probably incorrect. So that you have to do the difficult task of passing on the information, the relevant information, which means you need to vote up on everything and be able to disseminate that information to the children. Thank you.
Yes. Yes, Ralph?
Yes, you just to follow on from the last comment. I think that in general we need to look again at the way in which we do things like health and family life education. I think that young people are a lot wiser, and sometimes we make assumptions about, it still needs to be age appropriate, but I think sometimes we make assumptions about what should give to them. I think that the comments that have been made in terms of the way in which we deliver that material are well taken, and we really need, in the context of, say, the human resource development strategy, to look at ways of reaching young people. I don't think we can continue to try to reach them in the ways that we have been. And I wanted to comment on the Champions for Change. I think that was a very, very good initiative. We have tried it in the context of crime and violence, and we found it useful. And so I think we need to use it in other areas as well. I think that the point that Dr. Greene made about looking at things cross-sectorally is also one that we need to take on board, and one that we have been looking at within the context of the strategy, that we can no longer look at single issues, but that we need to, across of human resource development in particular, try to integrate and show people the connections between. And I think that the Every Caribbean Woman, Every Caribbean Child initiative is an excellent opportunity for doing some of that and for reviving some of that. Thank you.
Yes,
I want to support the intervention just made by Ms. Bernard in relation to intersectorality, or the intersectoral approaches needed to address the challenges. I think in particular we here in the Secretariat, we need to disabuse ourselves from the notion that health means injections and tablets. A lot of the work that needs to be done in health and in other parts of the social sector requires tremendous collaboration between and among other disciplines that are involved as stakeholders in the changes which are required. And I think the mechanisms by which the organs of the community can work in an integrated way to support some of these changes is going to be very, very important. There's not yet a distinct and real understanding of the kind of collaborative work that the organs themselves need to be done. That is the work that needs to go on between HSD and TEI, or HSD and FCR and so on, or legal, for example. These things need to be much better understood than they are currently understood across the board in the Secretariat.
Yes, and that's the reason why we're having this session. And next week, Monday, the 17th, we're going to have another session. And we're going to have a session with the children of our staff. That's also important. And you mentioned it, the intersectoral collaboration, cooperation, it's very, very crucial. So I'm glad that, HSD, TEI is here. Legal, no, but even people from California and so on, so I think it's really important. Any other questions or comments? No. Before I close then, I had said that, when I went around, that please come, you might miss something. But before I continue, Mr. Christian, right?
Yes.
I'm glad that you came in, you joined, and you asked the questions. Because we had to convince him he was going upstairs with his document that he has there. And we said, but it's lunch, come in. And you see, you came in, you did the value adding to, with all the questions and so on. So, sir, this is for you. You're not following the lottery part, but sure you can use this. Watch your one thing, right? So you, thank you very much. May we have the envelope, please, so that we can make sure that on the 17th you're also part of the session and bring your colleagues and so on with you. Some competition is good. Dr. Greene? One, yes. The number which is
It's black.
no, it's the number.
Oh.
Oh my, is it a 9 or a 6? I don't know.
6.
It's a 6.
6.
6? Who has number 6? Please.
Yeah.
19? 19?
Okay,
Oh,
Jim.
yes. Okay, please make sure that Ms. Wheaton writes your name on the inside, right? So that was it then. Thank you very much, everyone, for being here. And again, Dr. Greene, Dr. Cummings, Mr. Springer, Ms. Bernard, everyone. I hope you will have a fruitful afternoon, I would say, and I will see you next week, Monday, during lunch. And bring your colleagues along, please. We're having it then across the road. There is where we will have the session, okay? Thank you.